Hello, hello, dear students. Let's continue with chapter 52 and one of our favorite topics, appendicitis. Okay, appendicitis is an acute inflammation of the vermiform appendix that occurs most often among young adults. It is the most common cause of right lower quadrant pain. That does not mean that it cannot happen in older adults, okay, or seniors. There's another name for that particular type of appendicitis, but the one we are studying right now is the one, right, that is most often among young adults. The appendix usually extends off the proximal cecum of the colon just below the ileocecal valve. Inflammation occurs when the lumen, the opening of the appendix, is obstructed, is blocked, leading to infection as bacteria invade the wall of the appendix. The initial obstruction is usually a result of fecalites, very hard pieces of feces composed of calcium phosphate, rich mucus, and inorganic salts. So this whole picture results in pain, and if the process occurs slowly, an abscess may develop, but a rapid process may result in peritonitis. We discussed peritonitis in a previous video. Gangrene and sepsis can occur within 24 to 36 hours, are life-threatening, and are some of the most common indications for emergency surgery. 24 to 36 hours is, even though this is a life-threatening condition, is given us some time to go to the ER. Okay, is enough time to go to the ER and being treated. Perforation may develop within 24 hours, but the risk rises rapidly after 48 hours. Okay, the problem here is that since this condition is among young adults, most of the people is in denial, so they are waiting the very last minute to take action for this condition. Perforation of the appendix results in peritonitis with a temperature of greater than 101 and the rise in pulse rate. So let's see a video. Let's watch a video, okay, to understand a little bit more about appendicitis. Here we go.
Removal of the appendix, called appendectomy, is performed when appendicitis is suspected. Right lower abdominal pain, fever, and elevated white blood cell count are common symptoms and signs of appendicitis, which usually occurs when a blockage develops between the appendix and the intestine. This leads to infection, swelling, and distension. If the appendix is not removed, it can lead to a life-threatening perforation or rupture. The only treatment for appendicitis is appendectomy, which is almost always performed on an emergency basis.
Perfect. Thank you so much. Okay, so let's go here. We see this image. We have the umbilicus here in the center, and also we have the
The appendix
McBurney
is the
point.
little one-ended tube that's attached to the cecum of the large
Sorry,
intestine.
somebody wants to participate in our presentation. Okay, so let's go and see the image. Here we have the umbilicus, the left upper quadrant, right lower, left lower quadrant, and we have the McBurney point here, right? Is where the small intestine and the beginning of the large intestine starts, very close to the appendix, right? This is the anterior iliac crest. Okay, so you know what it is. That's the McBurney point. Assessment. How are we going to recognize the signs and symptoms, right? So there's another video that I want to show you about the McBurney point, but this time is the McBurney assessment. Okay, is, as I told you, NCLEX is full of the of signs and tests, and you need to master them. Okay, let's go and see.
If your case involves appendicitis or problems with the appendix, the student might start by testing McBurney's point, which is located 1/3 of the way between the belly button and the ASIS. The student should push down, at which point there would be tenderness on removing the fingers. This would indicate appendicitis or peritoneal irritation. The next test is Robson's sign, which is when there is pain in the right lower quadrant when the doctor pushes on the left lower quadrant. This as well indicates possible appendicitis. The next test is the iliopsoas test. In this test, on the right, with the right leg, the doctor flexes the hip and knee up to 90 degrees and has the patient pull their knee towards their head. This is activating the iliopsoas muscle, which might be irritated if the appendix is irritating that iliopsoas muscle. The last test is the obturator muscle test. This is a passive test, so the patient shouldn't be doing anything. The doctor goes ahead and flexes the hip and knee up and internally rotates that hip. This test would be positive if the obturator muscle is irritated from inflammation or from a ruptured appendix.
Perfect. So there you go. You learned 3 different assessments for the appendicitis. Okay. Plus, there was one that I shown in another
What's up,
class.
YouTube? How we doing?
Okay. There is one that I show in class. That is the one that you have to kind of push the wall while you are stand up and kind of you are jumping on your on your um on your toes. But you know, with these 3 is more than enough. Okay, so history taking and tracking the sequence of symptoms are important because nausea and vomiting before abdominal pain can indicate gastroenteritis. I gave you a hint in the other class. Appendicitis starts with A and P, abdominal pain first, and then you're gonna have the fever and the temperature. Gastroenteritis, you see, let's review this. History taking and tracking the sequence of symptoms are important because nausea and vomiting before abdominal pain can indicate gastroenteritis before abdominal pain. Abdominal pain followed by nausea and vomiting can indicate appendicitis. Classically, patients with appendicitis have cramping pain in the epigastric or periumbilical area. Anorexia is also a frequent symptom. Perform a complete pain assessment. Initially, pain can present anywhere in the abdomen or flank area. As the inflammation and infection progress, the pain becomes more severe and shifts to the right lower quadrant between the anterior iliac crest and the umbilicus. This area is referred to as the McBurney point. Abdominal pain that increases with cough or movement and is relieved by bending the right hip or the knee suggests perforation and peritonitis. Let me read it again. Abdominal pain that increases with cough or movement and is relieved by bending the right hip or the knee suggests perforation and peritonitis. Laboratory findings will show moderate elevation of the white blood cells count, which is leukocytosis, 10 to 18,000. We just saw on peritonitis that the WBC are going to be above 20,000. So in appendicitis, it's going to be between 10 and 18, with a shift to the left, an increased number of immature white blood cells. That is called shift to the left, when there is an increased number in the immature WBCs. A WBC elevation to greater than 20,000 may indicate a perforated appendix. Exactly, which is perforated appendix peritonitis. An ultrasound study may show the presence of an enlarged appendix. If symptoms are recurrent or prolonged, a CT scan may be used to diagnose and may reveal the presence of a fecaloma, a small stone of feces. What interventions are we going to do? All patients with suspected or confirmed appendicitis are hospitalized. So the non-surgical management, keep the patient with suspect or known appendicitis, NPO, nothing per oral, to prepare for the probability of surgery and to avoid making the inflammation worse. Be sure that the patient's pain is adequately managed before surgical intervention. Again, treat the symptoms. Nursing safety priority. Action alert. Patient with suspected appendicitis administer IV fluids as prescribed to maintain fluid and electrolyte balance and replace fluid volume. If tolerated, advise the patient to maintain a semi-Fowler position so that the abdominal drainage can be contained in the lower abdomen. Administer opioid analgesics and antibiotics as prescribed. The patient with suspected or confirmed appendicitis should not receive laxatives or enemas, which can cause perforation of the appendix. Do not apply heat to the abdomen because this may increase circulation to the appendix and result in increased inflammation and perforation. Let me repeat it again. No enemas, no laxative to avoid perforation of the appendix, no heat to the abdomen, okay, because this may increase circulation to the appendix, and again, it also can result in inflammation and perforation. Surgical management. An appendectomy is a removal of an inflamed appendix. Uncomplicated appendectomy procedures are done via laparoscopy. It's a minimally invasive surgery. A procedure known as natural orifice transluminal endoscopic surgery, NOTES, transvaginal endoscopic appendectomy, does not require an external skin excision. During this procedure, the surgeon places the endoscope into the vagina and other orifice that makes a small incision to enter the peritoneal space. Patients having any type of laparoscopic procedure are typically discharged the same day of surgery with less pain and few complications after discharge. Most patients can return to usual activities within 1 to 2 weeks. If the diagnosis is not definitive but the patient is a high risk for complications from suspected appendicitis, the surgeon may perform an exploratory laparotomy. And we know that that type of surgery is an open surgical approach. Help the patient out of bed after the procedure on the evening of surgery to help prevent respiratory complications such as atelectasis. He or she may be hospitalized for as long as 3 to 5 days and return to usual activity in 4 to 6 weeks, right? Okay, let's continue with gastroenteritis. Gastroenteritis is a very common health problem worldwide that causes diarrhea and or vomiting related to inflammation of the mucous membranes of the stomach and intestinal tract. The small bowel is most commonly affected and it can be caused by either viral, more common, or bacterial, right? So, gastroenteritis, viral, or bacterial infection. Common types of gastroenteritis and their characteristics. Viral gastroenteritis. It could be epidemic viral. Incubation period is 10 to 15 hours, right? And transmitted via the fecal oral route in food and water. Norovirus, Norwalk viruses, incubation in 48 hours, so it's 2 days. Transmitted by the fecal oral route and possibly the respiratory route, vomitus. older adults can become hypovolemic and experience electrolyte imbalance with the norovirus. Bacterial gastroenteritis, Campylobacter enteritis, incubation 1 to 10 days, communicable for 2 to 7 weeks. Note the difference between the viral incubation period and the bacterial. One is, the first two are in hours, the bacterial is in days. Escherichia diarrhea, transmitted by fecal contamination of food, water, or fomites. Shigellosis, incubation period 1 to 7 days. Communicable during the acute illness to 4 weeks after the illness. Human possibly carries for months. Shigellosis. Okay, so basically bacterial is incubation period within days, 1 to 10 days, let's say in average. And the viral is going to be almost immediately, between 2 and 3 days. Norovirus, also known as Norwalk-like virus, is the leading foodborne disease that causes gastroenteritis. It occurs most often between November and April because it is resistant to low temperatures and has a long viral shedding before and after the illness. So we are now in November, so this is the time of the norovirus. Infected individuals can also contaminate surfaces and objects in the environment. Surfaces and objects in the environment. Vomiting may cause the virus to become airborne. Ooh, wow. What is viral sharing? Viral sharing. What happened here? Okay. Viral sharing is when a person is infected with a virus and the virus multiplies in the body and can be released into the environment through sneezing, coughing, or even speaking. This release is called shedding. And viral shedding is how COVID-19 is spread from person to person. How long a person who has COVID-19 will shed virus is still unknown. That's why I included this explanation in this video, because when a person is having COVID, basically is spreading the virus for how long? We don't know. Okay. In most cases of gastroenteritis, the illness is self-limiting and lasts about 3 days. However, in those who are immunosuppressed or in older adults, dehydration and hypovolemia can occur as complications requiring medical attention and possible hospitalization. Health promotion and maintenance. Outbreak of norovirus have occurred in prisons, on cruise ships, and in nursing homes, college dormitories, and other places where large groups of people are in close proximity. Teach individuals that hand washing and sanitizing surfaces and other environmental items help prevent the spread of the illness. Okay, so be careful when you are in the train, in the bus, and you're touching, the handles. Now you understand why some people is so cautious, and they go to the supermarkets with gloves, and they are touching the shopping carts with gloves, or they are cleaning the shopping carts with the sanitizers, right? The towels, the sanitizer towels. It's not because they are scared, it's because they are preventing infections. Assessment. Ask about recent travel, especially to tropical regions of Asia, Africa, Mexico, or Central or South America, because these areas historically have been a source of gastroenteritis. Inquire if the patient has eaten at any restaurant in the past 24 to 36 hours. Some people acquire gastroenteritis from eating in fast food restaurants or from food items purchased at a farmer market or grocery store. Bacterial infections have caused large outbreaks that resulted from contaminated spinach and lettuce in the United States. Raw or undercooked food such as oysters, sushi, and rare meat can also cause GI infections. Nausea and vomiting typically occur first, followed by abdominal cramping and diarrhea. So, nursing safety. For patients with gastroenteritis, note any abdominal distension and listen for hyperactive bowel sounds. Depending on the amount of fluids and electrolytes lost through diarrhea and vomiting, depending on the amount of fluids and electrolyte lost through diarrhea and vomiting, patients may have varying degrees of dehydration manifested by poor skin turgor, and we know how to assess for skin turgor. Orthostatic blood pressure changes, which can cause a fall, especially for older adults. The other signs and symptoms described in this list is common sense: weight loss, fever, because of the dry mucous membranes, hypotension, oliguria, which is a decrease or absent urinary output. Monitor mental status changes, such as acute confusion that result from hypoxia due to dehydration in the older adults. Interventions. Teach patient to drink extra fluids to replace fluid loss through vomiting and diarrhea. Oral rehydration therapy, ORT, may be needed for some patients to replace fluid and electrolytes. Examples of ORT solutions include sport drinks and Pedialyte. Now, I want to bring to your attention the BRAT diet. I'm sure you heard about it, or maybe you studied in the nutrition course. Recommended for people with vomiting, diarrhea, or gastroenteritis. The diet consists of food low in fiber that are gentle in the stomach, like bananas, rice, applesauce, toast, cracker, and chicken broth. Is the BRAT diet. B, banana, R, rice, A, applesauce, T, toast. Okay? Drugs that suppress intestinal motility may not be given for bacterial or viral gastroenteritis. Use of these drugs can prevent the infecting organism from being eliminated from the body. Okay. Treatment with antibiotics may be needed if the gastroenteritis is caused by bacterial infection with fever and severe diarrhea. Ciprofloxacin or azithromycin are the choices. If the gastroenteritis is caused by shigellosis, anti-infective agents such as Cipro, ceftriaxone, or azithromycin are prescribed. Protective barrier cream can be applied to the skin between stools. Sitz baths for 10 minutes 2 or 3 times daily can also relieve discomfort. Patient and family education, preventing transmission of gastroenteritis. Wash your hands, restrict the use of glasses, dishes, eating utensils, and tubes of toothpaste for his or her own use. In severe cases, disposable utensils may be used. Maintain clean bathroom facilities to avoid exposure to stool. Do not prepare or handle food that will be consumed by others. If you, the patient, are employed as a food handler, the public health department should be consulted for recommendations about the return to work. Okay, and here there is a table that I'm assuming belongs to the next topic. So here we conclude appendicitis and gastroenteritis.